Good afternoon and welcome to this session on heart failure in pediatric population. Welcome to the 2025 Asian Cardiovascular Clinical Research Seminar. This session is on behalf of the Heart Failure Council of the Asian Heart Society. So we have four talks in this session. The session is basically focused on pediatric heart failure, which is we know that it is an upcoming area, and we have more and more developments happening in this, the advancement of new drugs, new techniques, and the improvement in heart failure in general. I think pediatric population also will benefit. So the first talk will be by Dr. Arun Gopalakrishnan, who is additional professor in cardiology at Sri Chitra Institute in Trivandrum. So he will be speaking on SGLT2 inhibitors, basically dapagliflozin in pediatric heart failure. Over to Dr. Arun.
Thank you.
And share your slides.
Thank you, sir.
Yeah, can you make it full screen, please? Yeah, we can hear you and see the slides. Please proceed.
So thank you very much. I should thank the 2025 Asian Cardiovascular Research Clinical Research Seminar for having me. The talk is on SGLT2 inhibitors in pediatric heart failure. So what is SGLT2 inhibitors? They refer to sodium glucose co-transporter 2 inhibitors and simply termed as gliflozins as well. It started as anti-diabetic drugs, and the drug acts primarily on the kidneys. So what are SGLT? SGLT are refer to receptors which are present on the brush border surface of the proximal convoluted tubules. That is the SGLT2, which is present in the proximal part. That is the first and second parts of the proximal convoluted tubule. And its primary action is to reabsorb sodium and glucose by co-transport, while the rest, what is not taken back by the SGLT2, is reabsorbed by SGLT1 in the distal part of the proximal convoluted tubule. As opposed to what is the GLUT is another set of receptors which is present on the basolateral part of the proximal convoluted tubule and is an energy-dependent transport. So that is what SGLT2 inhibitors inhibit this process and leads to natriuresis and excretion of glucose. So when did SGLT2 come up in heart failure? The journey started in 2015 with the EMPIRIC outcome trial, which was initially studied in diabetic patients. It showed an improvement in the primary composite outcome and death from cardiovascular causes and cardiovascular death and hospitalization in patients who were taking empagliflozin, who were diabetic. A similar study was tried with canagliflozin. Although it reduced the composite outcome, there was an increased incidence of amputation. So the concern was raised regarding the entire class of drugs. Then came the DECLARE 58 trial in 2019, which improved the composite outcome, but not the MACE rate. And again, the impact of dapagliflozin was not clear. Then the landmark trial, DAPA-HF, came in 2019, where the primary outcome were improved, hospitalization for heart failure, death from cardiovascular causes, and all-cause mortality were improved by dapagliflozin. And similar studies were attempted in empagliflozin. Here, the EMPEROR-REDUCE trial showed improvement in the primary outcome and in heart failure, but did not improve death. And subsequent a host of studies came, and the rest is history. So what is the benefit of SGLT2 in heart failure? It has been documented to be beneficial in acute heart failure and chronic heart failure across all classes of LV ejection fraction in data from adults. There is a 31% reduction in heart failure hospitalization, and that is based on some of the trials which we discussed. There is also a composite dual SGLT inhibitor which is being studied. The SOLOIST WHF trial documented the benefits of sotagliflozin in reducing the composite outcome by 33%. So much so that SGLT2 is now considered a class 1 drug for heart failure across all ranges of ejection fraction uniformly by the Americans, European Society, and the latest published Japanese Heart Failure Society. Now, where do we stand in pediatric heart failure? SGLT2 inhibitor, there is no randomized data so far, no large-scale studies. This is our study which was recently published regarding the efficacy and safety of dapagliflozin in pediatric heart failure, the largest study till date on this molecule in pediatric heart failure. Our children were aged 11, the median age was 11, 49 children were studied. Majority had a dilated cardiomyopathy and followed by congenital heart disease. There were a few children with pacing-induced cardiomyopathy, tachycardia-induced cardiomyopathy, and chemotherapeutic cardiotoxicity as well. The mean ejection fraction was 35%, and they were followed up for a median of 206 days, and 34% of them met the primary composite outcome of worsening heart failure, heart transplantation, or mortality, suggesting that the children were very sick. This was a retrospective observational study, and 9 children, that is 18%, had died within this period, and 2 underwent transplantation. So these are the children who died. 9 of them died primarily because of pump failure, and there were 1 death each due to sepsis and due to spiral and non-courses at home. But none of them reported the classical adverse events which we were screening for SGLT2 inhibitors. We noted a significant improvement in LV ejection fraction from 35 to 39.5% for a 6-month follow-up, and an improvement in functional class as well. ProBNP levels, NT-proBNP levels decreased from 2,600 to 1,100, but it did not meet statistical significance. Majority of our children were on other drugs which are conventionally used for adult heart failure, the 3 pillars, that is beta blockers in 78%, RAS inhibitors in 96%, and spironolactone in 92%, triple therapy in 71%. Most improvement was noted in those who had post-myocarditis sequelae, and even in those who did not have history of myocarditis but had idiopathic dilated cardiomyopathy. There was an improvement in LV ejection fraction, but it did not meet the p-value for significance. In congenital heart disease in other patients, it was neutral. This was the list of adverse events which we identified. Sterile pyuria was noted in 3 children. 1 child had genital candidiasis. There was no child with hypotension, and serum creatinine and GFR remained more or less similar. But at the same time, we must admit that real parameters were not reported at every visit. This was not a prospective study. And we used dapagliflozin at a dose of 0.1 to 0.2 milligram per kilogram per day based on observational studies. There is no pharmacokinetic, pharmacodynamic studies of dapagliflozin in pediatric heart failure till date. And also the incremental benefit of SGLT2 inhibitors to other GDMT cannot be commented based on retrospective studies. At the same time, this is one patient, the child who had genital candidiasis, was a child with complex congenital heart disease and dextrocardia and significant LV dysfunction. You can see the child's status when the child was on at baseline with a significant cardiomegaly. After initiation of SGLT2 inhibitor, there was significant reduction in cardiac size. And at 12 months of therapy, the child developed genital candidiasis. We had to stop SGLT2 inhibitors. But 1 month later, the child came back with worsening LV function, and there was an increase in cardiomegaly as well. After counseling the parents and with close medical follow-up, we restarted SGLT2 inhibitors, and cardiomegaly improved with improvement in ejection fraction. There are data from other studies as well. The elegant paper by Newland et al. Was published in Pediatric Cardiology in 2023. They reported 38 patients with a median age of 12.2 years, majority dilated cardiomyopathy, and close to 20% were univentricular heart disease. Their study reported a significant decrease in BNP levels on follow-up, and the UTI rates were much higher. In their subset of with the dilated cardiomyopathy, they reported an improvement in LV ejection fraction over a median of 313 days. A closer look at the result shows significant improvement in LV, symptomatic class by NYHA. Blood pressure remained identical. LV ejection fraction improved. BNP improved. eGFR, however, showed a trend to decline a bit, and the hemoglobin levels had gone up a bit, and the usage of other cornerstones of heart failure, were to the tune of around 70% lesser than in our study. They also reported another elegant paper whether dapagliflozin can be considered in children who are listed for heart transplant. 22 children were compared with 44 matched controls. There were no significant differences in their blood glucose nadirs, ABG parameters, or vasoactive medication or insulin use. No deaths. The ICU stay and time to discharge was identical in those who were considered for transplant, and there was no incidence of euglycemic ketoacidosis, which is a concern that has been reported from adult literature. There is overwhelming evidence regarding adult congenital heart disease where SGLT2 has been improved, has shown benefit in heart failure hospitalization rates. This is the paper from Nathan Horst in 2024. SGLT2 inhibitors have been tried in univentricular failure. This is the paper from Michigan by Conduring. 14 patients with fountain circulation. Again, the dose of dapagliflozin is similar. They also tried one child on empagliflozin. Half of their patients had reduced ejection fraction and half of the patients had preserved ejection fraction. And they reported no change in ventricular function or in NYHA class, but they were well tolerated. But at the same time, we must say that there was an improvement in NT-proBNP levels, but they reported decline in eGFR over the period of follow-up and creatinine levels. Talking about SGLT2 in LV function, there is emerging evidence regarding their role in RV dysfunction as well, and that comes from adult studies initially, and it has been investigated in children as well. SGLT2 has multiple mechanisms of action. It improves the preload. It is not a long-acting natriuretic, but it improves osmotic diuresis and it reduces diuretic resistance. And it has favorable effects on volume handling, pulmonary artery remodeling, and over a long period of time, there is favorable effects on the renin-angiotensin system as well. The paper from Toronto by Biswajit, they reported decrease in pulmonary artery pressures with empagliflozin in a rat model on follow-up. So the benefits of SGLT2 have been documented in both ventricles by multiple mechanisms. It is beyond the scope of one talk to discuss the overall mechanisms of SGLT2 inhibitors, but this paper by Connelly, where PA banding was tried in rats, we expect RV pressures to go up and RVH to worsen. After the RVH had set in, these rats were put on dapagliflozin, and they documented decrease in right ventricular thickness, and that documented the putative role of SGLT2 inhibitors in right heart function. There are multiple mechanisms to the overall summary of the slide is that SGLT2 inhibitors positively regulate the nutrient deprivation signals and negatively act on nutrient surplus signals. These are all housekeeping gene mechanisms. It has favorable action on the calcium homeostasis and reduces stress and inflammation. This is elegantly reported in this paper by Travis D'Souza 3 years back. So what do the trials show? Addition of SGLT2 inhibitors to GDMP resulted in greater improvement in right ventricular function in patients with HFrEF. The paper in 2022 by Ivana Mistepik. Schuster reported the DAPA-SERVE trial last year. They reported 50 patients and noted to have improvement in RV, FAC and RVGLS, but at the cost of mild decline in eGFR. There is no formal studies on SGLT2 inhibitors in RV dysfunction till yet, so PIDA data is awaited. What about the data on systemic RV function? There is a paper by Nathan Horst from Leiden University, just published 2 years back. They reported 10 patients at a median of 50 years and documented improvement in NIHA class, 6-minute walk distance, and NT-proBNP levels over follow-up. At the same time, there was a mild decline in eGFR. Our unpublished data on children, Nathan Horst paper was in adults. Our data so far shows favorable response in children, and I cannot disclose more at this point. SGLT2 inhibitors in chemotherapy-related LV dysfunction is another area where there is active research ongoing. Multiple mechanisms have been postulated. It reduces inflammation by inhibiting reactive oxygen species and inflammatory cytokine production. There is ongoing research regarding its application for prevention and treatment of anthracycline-induced cardiotoxicity. There are multiple clinical trials in adults involving empagliflozin, dapagliflozin, and canagliflozin, and there are ongoing trials in pediatric cancers and leukemia. So SGLT2 has been known to be expressed in several human cancers. They include thyroid cancer, lung cancer, kidney, prostate, breast, and of interest in children is primarily brain tumors. Astrocytoma, childhood astrocytomas is the area where it has been primarily tried. And at the same time, I must say that there is evidence going. There are trials going on in pediatric leukemias for the prevention of cancer chemotherapy-related toxicity. There is a case report regarding SGLT2 application in pediatric hypertrophic cardiomyopathy from Spain, where they reported 3 patients, 2 of them who had post-myectomy, and empagliflozin was tried, resulted in symptomatic improvement and decrease in NT-proBNP levels, but the data is too early to give conclusions. So in summary, there are pleiotropic actions of SGLT2 inhibitors. There is favorable data from observational studies that show clinical improvement in 6-minute walk distance, NYHA class, improvement in LV function, HFrEF, and improvement in natriuretic peptides. Renal function, there is a concern. The optimal dose in pediatric heart failure is uncertain. There are no pharmacodynamic studies so far in pediatric heart failure. And as Sebastiano Lava put up yesterday, there is a need for prospective studies in this cohort. Thank you.
Okay, very good topic. Actually, we will discuss in the later. Okay, so
Yes.
anyway, it's a very nice introduce some new data on this. Actually, for us, we haven't used this kind of medicine in children with heart failure. We will discuss later. So I will introduce the second speaker from Beijing, and Dr. Dai Chen. She will talk about the pediatric arrhythmia related cardiomyopathy. Actually, we have seen less and less dilated cardiomyopathies in our clinic setting, and this arrhythmia related cardiomyopathy sometimes before it's not so common, but now we see more and more. And Dr. Dai, she is from the cardiovascular hospital in Beijing. She will introduce some her experience and some data on this topic. Dr. Dai, please.
Thanks for the introduction for Professor Du. I'm Dai Chen, come from Beijing Anzhen Hospital, the Department of Pediatric Cardiology. My topic today is arrhythmia-related pediatric cardiomyopathy. My topic will include 3 parts. The first part is the first type is ventricular pre-excitation-induced dilated cardiomyopathy. The second type of cardiomyopathy is tachycardia-induced cardiomyopathy. The third part is complete left bundle branch block related dilated cardiomyopathy. The first part, in 2013, we first reported 4 cases of ventricular pre-excitation-induced dilated cardiomyopathy. All the cases were originally diagnosed with idiopathic dilated cardiomyopathy. The patients didn't get good response to anti-heart failure medication. However, after successful ablation, all the patients get totally recovery of the ventricular function and size. Now let's come to the diagnostic criteria of this type of cardiomyopathy. First, it should meet diagnostic criteria for dilated cardiomyopathy. Secondly, ECG showed type B ventricular pre-excitation. That means the accessory pathways lies in the tricuspid annulus. Third one, we should exclude the tachycardia-induced cardiomyopathy. Fourth, it is very important. We can observe left ventricular systolic dysfunction by M-mode echo, tissue Doppler, and speckle tracing. we can see thinning and paradoximal movement of the ventricular septum. I will show you later by the movie. Through successful ablation, left ventricular systolic synchronicity is restored. Cardiac function gradually returns to normal, and the left ventricular reverse remodeling. The left picture shows the basal and middle segments of the interventricular septum moved like an aneurysm before ablation. And the M mode shows the interventricular septum and the posterior wall of the left ventricle moves in the same direction. It is abnormal. After ablation, the abnormal interventricular septum movement disappeared, and the synchronicity improved after ablation by M mode. This is the pictures results from 2D scan. Before ablation, we can see the basal and the middle segment of the interventricular septum moved in the opposite direction with other segments. It is quite dysynchronous contraction of left ventricle. After ablation, all of the segments of left ventricle moved at the peak systolic strain at the same time. So after ablation, the left ventricle contracts synchronously. The bull's eye of left ventricle longitudinal strain shows before ablation, the blue areas moved the opposite direction with other segments. After ablation, the bull's eye strain shows all the segments moved good. And this is the pictures from circumferential strain. Also shows before ablation, it is not moved synchronously. After that, we had a prospective study. The conclusion of this article is that right-sided accessory pathways may impair ventricular wall motion and resulting in decreased left ventricular injection fraction and increased left and diastolic diameter. Our papers were cited by PACE consensus in 2016 and ESC guideline in 2019. So I want to show that identification of ventricular pre-excitation-induced dilated cardiomyopathy can transform the patient's prognosis because this kind of cardiomyopathy can be cured. It is different from idiopathic cardiomyopathy. Now, the second part of my presentation, that is tachycardia-induced cardiomyopathy. We all know TIC is more prevalent in children than in adults. TIC can result from sustained SVT, AT, or VT. Among these tachycardia, AT accounts for about 28% TIC in children. However, the number is 8 to 10% in adults. They are different. The onset of TIC can be acute or insidious. Some cases showed incessant tachycardia with relatively moderate heart rates. If the children had rapid heart rates, maybe they will go to the doctor earlier, and it can prevent the happening of TIC. TIC usually had a poor response to antiarrhythmic drugs. The preferred treatment is catheter ablation for children older than 3 years old. Most cases can get total recovery through ablation. So early recognition, early intervention is very important. For patients younger than 3 years old, combined antiarrhythmic drugs are recommended. I have 2 cases for you. Case 1, this is a boy 8 years old, 28 kilogram. He had a 5-year history of tachycardia. When he was 3 years old, the Holter shows sinus rhythm, average heart rate 126 BPM. The echo and the BNP were normal. When 9 months ago, he was diagnosed with dilated cardiomyopathy at a local hospital because fatigue. Despite guideline-directed medical therapy for heart failure combined with antiarrhythmic drugs, our left ventricular injecting fracture fluctuates between 28 and 50, never normal. 200 average ventricular rate is 112. Echo at admission, LVEF is 40%, and LVEDD is 49 millimeter. This is an episode of Holter. In this episode, we can see the first 4 beats, the P wave is positive, and from the fifth QRS, the P wave is totally negative. This indicated the existence of AT. However, we don't know whether AT attributes totally to the cardiomyopathy. We perform ablation for this patient. Electrophysical mapping indicated AT originating from right atrium appendage. Quite fortunately, the patient we done a successful ablation, and the child get normal sinus rhythm. 1 month later, the ECG and the echo were all normal, so this boy is cured. Case 2, it is a female, also 8 years old, 20 kilogram. Her chief complaint is intermittent palpitations and dizziness for 4 years. He had fatigue for 2 months, worsening and combined with shortness of breath over the past 2 weeks. Echo shows left ventricular ejection fraction is only 20%, and LVEDD is 64 millimeter. It's quite huge. BNP is significantly increased. So in local hospital, she was advised to take heart transplantation because of end-stage heart failure. When the girl comes to me, I read the Holter. Average heart rhythm heart rate is 97 BPM. PVC is less than 20,000 to 24 hours. Let's see the Holter. Some PVC and also can accelerated ventricular rhythm can be seen. This picture shows tachycardia 4 years ago. It is a narrow QRS tachycardia. We can see VA dissociation, so it is a VT episode. At that time, echo was normal, and 3 years ago, echo is also normal, despite the tachycardia will attack. These recent 2 years, the tachycardia happens less, and no exertional limitations during routine activities. So she didn't go to hospital. When she in our department, the echo shows global left ventricular hypokinesis. LVEF is just 21%, and LVEDD is 66 millimeter. This is the EKG. When then it comes to the therapy, besides anti-heart failure medicines, I give her continuous infusion of amdalone. After amdalone, I find that mental status and appetite of this girl improved, and the dizziness resolved. And the most important thing is that invasive arterial blood pressure elevated. So I think it tells me that the ventricular rhythm do harm to her heart function. So she may benefit from ablation. We are very lucky, and it is a hard thing to ablate this kind of ventricular tachycardia. It originated from left anterior papillary muscle. After successful ablation, the girl get normal left ventricle size and the systolic function about half a year later, post-ablation. So this girl is also cured by ablation. So when we in clinical practice, we have such kind of questions, such as, is observed left ventricle dysfunction entirely or partially attributed to the tachycardia? Does heart failure exacerbate arrhythmias, or is this case is a TIC? And we will have doubt that whether we can get complete recovery of cardiomyopathy after arrhythmia resolved. My answer is that even in patients with established etiology for dilated cardiomyopathy, suspicion for TIC should be maintained, and active management of arrhythmia should still be pursued to obtain potential clinical benefits. And the third part of my presentation is complete left bundle branch block and dilated cardiomyopathy. The relationship between these two has been well known in adult patients. However, in pediatric patients, there are few researchers, just case reports. We think if this synchronous ventricular wall motion exists, the child may benefit from cardiac resynchronization therapy. I have also a case. This boy is 3 years and 8 months, just 11 kilograms. He had cardiac dysfunction and dilation of left ventricle for about 3 years and 5 months. He was admitted to a local hospital due to cough and paler when he was 2 months old. Echo showed globally dilated left ventricle. LV-EDD is 52 millimeter, and left LVEF is just 30%. Desynchronous ventricle septal motion and moderate mitral and tricuspid regurgitation. BNP is very high, and the ECG shows left bundle branch block. When the boy's fetal echo shows desynchronous ventricular septal motion with a bunching sign. The daughter drew a conclusion, ventricular pre-excitation or left bundle branch block. His mother had lots of autoimmune antibodies positive. Symptoms improved after anti-infective and anti-heart failure therapy. Echo at discharge showed LV-EDD 33 millimeter and LVEF was 31%. His therapy includes anti-heart failure drugs and IVIG and prednisone. When the boy comes to me, growth retardation and prominent precordial bulge is very impressive. This is his EKG. See, left bundle branch block, and the QRS is very wide. This is the echo. We can see the huge left ventricle, and the septum moves towards the right ventricle. LVEDD is 55 millimeter, LVEF 38%. And even we can observe right ventricle outflow tract stenosis because of the huge left ventricle. This is the MI. LGE of left ventricle can be observed, but it is not very serious. I perform LBBP for this child. This is the ventricle lead, and this is the atrial lead. This shows the huge left ventricle. The procedure is quite hard, but we get narrow QRS after pacing. After pacing, the boy get improved clinical changes. It is the first time for the boy sleep through the night without waking after birth, and we are very lucky, no complications related to the procedure. And echo shows improved synchronism between the two ventricles. And this is the ECG after 80 days after pacing, and the pocket excellent hearing. We see the echo 80 days after LBBP. It is very good, and EF biplan is 55%, and LVEDD is 38 millimeter. And 2D strain also shows the boy get synchronous left ventricle contraction through pacing LBBP. And 2 years later, the 2D strain also shows excellent results. And 2 years after LBBP, it is very good. The LEF is normal, and the LVEDD is also normal. So this is the EKG 3 years after LBBP, also narrow QRS. Summary, pediatric dilated cardiomyopathy has complex etiologies, such as genetic metabolic origin, inflammatory, idiopathic dilated cardiomyopathy, some rare etiologies such as endocrine causes, autoimmune diseases, and nutritional deficiencies. I will mention all. I want to emphasize that arrhythmia is also an important cause of dilated cardiomyopathy. When we encounter cases both has arrhythmia and dilated cardiomyopathy, maybe it's hard for us to distinguish the relationship between them, causality or just comorbidity. In our center, when anti-heart failure therapy cannot produce satisfactory effects, eliminate the arrhythmia, and then assess whether the child will benefit from it is our choice. And another thing is important is the timing of intervention. We should choose a proper time for intervention. Thank you.
Dr. Dai, that is a wonderful talk, very good cases. Thank you so much for highlighting this entity. We know that it is most of the patients it's a cure. That is the most important part. Now we'll move to the next talk on Eisenmenger syndrome, the management challenges by Dr. S. Ramakrishnan, who is the professor of cardiology at the prestigious All India Institute of Medical Sciences, New Delhi. Over to Dr. Ramakrishnan.
Thank you, Dr. Hari, and thank you for having me here. I think I would like to start. So, this August audience knows what is an Eisenmenger syndrome. And unfortunately, world's maybe 80% to 90% of all Eisenmengers belong to Asia. I think Asia has become the capital of Eisenmenger syndrome. And since it's not a very common Western disease, most of the management guidelines are not fully evolved. And you can see there are a lot of lacunae, and the data is limited as compared to other phases of Eisenmenger syndrome. So, what is the common classification of pulmonary hypertensive disease in congenital heart disease? So, this was the older one that NICE 2013 proposed. So, that's classical Eisenmenger syndrome, which includes all types of systemic pulmonary shunts, which lead to a reversal of shunt. That means either a bidirectional shunt or a right to left shunt that is happening. That's classical Eisenmenger syndrome. Then you have pulmonary hypertension associated with systemic to pulmonary shunts, but they don't have cyanosis at rest right now. And the pH with small defects, that means the pH is out of proportion pH, or the pulmonary hypertension that is occurring after corrective surgery. This now has been updated, and this is the latest the AHA guideline that came in 2023. This has classical, say, okay, like pH associated with intracardiac and extracardiac shunts. Then you have Eisenmenger syndrome. And now there is a group that has unrepaired congenital heart disease who can be possibly repairable or unrepairable. So this is another, again, a class which may not be called as Eisenmenger syndrome, but for practical purposes, they are inoperable. The reason we are not calling them Eisenmenger syndrome is that they are not at cyanosed at rest. Then you have the pH out of proportion to pH, and then some pH after surgical repair. So what are the type of pH that we are likely to encounter in Asian countries? It is more commonly Eisenmenger syndrome than idiopathic pulmonary hypertension or other forms of pulmonary hypertension like the CTPH and other things. So in a routine, as a routine in our country, whenever we find a patient with IPH, especially in an adolescent with IPH, we almost invariably do have a detailed look at the onset and the course of the disease, what are the history and when did it started, and almost always do a saline contrast echocardiography to rule out a subtle or a innocuous looking, which is missed intracardiac shunt. So that's a standard. So Eisenmenger syndrome in terms of clinical groups can be of three types. One is cyanosis since birth. These are the cyanosis with increased pulmonary blood flow situations like the transposition of great arteries, the DORVs with malposed vessels. Then you have the truncus arteriosus. All of them may have cyanosis from very early in infancy, and they become Eisenmenger very early. And generally, they don't live beyond, say maximum first decade or maximum second decade. So their longevity is not well known. And the classical prototype that we all want to have a picture is there is a history of failure to thrive in infancy. For some reason, the PSD was missed, or some other congenital heart disease was missed, or did not undergo surgery. And then there's a certain phase that happens, and then the patient comes with symptomatic adolescent phase. Or more commonly, around 40% of children or adolescents can just come with first time diagnosed with the intracardiac lesion, which was never diagnosed in infancy, or they never had a problem in infancy. They are thought to be because of a lack of reduction in the pulmonary hypertension or the PVRI of the childhood. So this is one of my polls that I want to just put to the audience. You can just scan the QR code with your mobile phone and start answering. My question is, at what age a large VSD will become Eisenmenger syndrome? So you can just screen the QR code and start answering. The audience are there, like you can screen the QR code and then start answering. So maybe I'm not getting any answers. Maybe I think let us not waste time. So the answer would be the large VSD with a may become inoperable by 2 years of age, but commonly they come with symptoms and reversal at around 10 to 20 years of age. So these are the differences. How do you differentiate clinically? Like from an ASD will have a right atrium and right ventricular enlargement. There will be cardiomegaly, whereas the VSD and PDA will not have a cardiomegaly. Whereas you can see a specific bulge in the PDA in some patients, and then differential cyanosis may be found also. So moving on to the management part. So how do you manage such a patient? So the pharmacotherapy, as you can see, will be very limited. So the most important management is the non-cardiac management. Not only that, Eisenmenger syndrome over time affects almost every system in the body. So I think the management should be focusing more on a holistic approach to all the systematic care. For example, they may have gout, they may have renal involvement, they can have various other system involvement, they may have brain abscess, and so on and so forth. So the most important thing is focusing on the non-cardiac management, the non-pharmacological cardiac management. That will be endocardial prophylaxis, anticoagulation and phlebotomy, the indication for oxygen therapy and targeted drug therapy, exercise training, and avoidance of non-cardiac surgery. They all form an important aspect in the management of Eisenmenger syndrome. So some of the more common, especially in our country and even Southeast Asia, some of the countries of SAARC countries, the South Asian countries also, phlebotomy is carried out without a reason. And phlebotomy is generally secondary erythrocytosis by itself doesn't increase the risk of stroke, but repeated phlebotomy can lead to iron deficiency, and that can increase the risk of stroke. So generally, it is reserved for a symptomatic patient who is symptomatic despite medical therapy, and it should not be a routinely done as a phlebotomy. It should not be routinely performed just by looking at the hemoglobin or the hematocrit. And iron deficiency should be ruled out in a patient with Eisenmenger syndrome. So another important problem that we all encounter in Eisenmenger syndrome management is the occurrence of hemoptysis. So hemoptysis, we all don't know what is the reason for hemoptysis. This is a systematic study that we performed in around 95 patients with Eisenmenger syndrome, out of whom we had 38 had hemoptysis and no hemoptysis was there in 57 patients. We did CT pulmonary angiogram and HRCT within 2 weeks of hemoptysis. In half of these 38 patients, we nearly found a cause. And that cause included aortopulmonary collaterals, rarely pseudoaneurysm, which needed a coil or a plug placement, pulmonary infarction, pulmonary artery thrombosis, and pulmonary tuberculosis was also found. So then all these patients with aortopulmonary collaterals underwent a coil or a gel foam occlusion of the aortopulmonary collateral. Then they were followed up, and the patients whom we found a cause, which was treated, they had a reduced recurrence of hemoptysis by around 50%. That establishes that possibly these aortopulmonary collaterals were the causes of hemoptysis, possibly. So this was my other question. Like, suppose moving on to the targeted pharmacotherapy. So, a 24-year-old male with a class 1 WHO functional class 2 Eisenmenger with a 6-minute walk distance of 320, the baseline resting saturation of 80%. What would be the drug therapy to start? Would you start on a furosemide with spironolactone combination? Would you start on a bosentan, a combination of ambrisentan and tadalafil, or selexipag? So what would be the treatment that you would be starting? Since I'm not expecting many people to answer this poll, so the answer here is even though in a classical idiopathic pulmonary hypertension, we always go for a combination therapy to start with. The answer here is most of the Eisenmenger syndromes do very well with a monotherapy. We'll discuss about it, why this discrepancy is there. So these are all the possible published studies of targeted drug therapy in Eisenmenger syndrome. So most well studied is the endothelin receptor antagonist in the form of bosentan. You can see most of the studies are on bosentan. The active drug is bosentan. Even though look at the numbers are not so great as compared to the other facets. We need more studies in that. So many of the hospitals in Asia would have seen more numbers than all the multicentric studies that are reported. The largest study being by the Gadzolis group, the RCT Breathe 5, it's 114 patients RCT. That's a larger study. That's a macitentan study. That's the largest study. So the 2006 RCT is only 37 patients. So most of all the institutions in Asia would have seen more number of patients than this. Like, and there are only one study of ambrisentan and one study of macitentan, and there are more studies of tadalafil, and very few studies of bipoprosteinol and idioprost, and with very small numbers of Eisenmenger syndrome. So Breathe 5 is the first RCT which was published in 2006 that showed a double-blind placebo-controlled trial with class 3 patients, 54 patients randomized into 2:1 to bosentan versus placebo. The follow-up of 16 weeks showed a significant improvement in 6-minute walk distance. It also significantly reduced the PVR, the mean pulmonary artery pressures, and significantly increased the 6-minute walk distance without compromising the oxygen saturation. So we all have to have a context in why this kind of small study was published in Circulation. At the same time, the same year, we also published from our group that there was a significant reduction in PA pressures with tadalafil. So at that time, the specific pulmonary vasculitis were thought to be contraindicated in Eisenmenger syndrome because they may reduce the BP, and then by the time they may increase the right to left shunt. They were thought to be not to be of help in Eisenmenger syndrome. These were the two studies that established that pulmonary vascular therapy is useful in Eisenmenger syndrome. Then, apart from the bosentan studies, the major studies of macitentan is the MASTRO trial, which had 226 Eisenmenger syndrome. The macitentan, unfortunately, did not show superiority over placebo. There is no significant improvement in WHO functional class. The mean change in baseline 6-minute walk distance was nearly the same. But even though there was more common adverse events, just the NT-proBNP levels decreased with macitentan compared to placebo. This was a negative study. So I told you, like, unlike in idiopathic pulmonary hypertension, where combination therapy is the treatment to go, the same is not true in Eisenmenger syndrome. That is because of these studies of combination that have been tried, even though these studies are grossly underpowered, and most of them looked at the 6-minute walk distance. And even though addition may be useful, but adding may not improve the 6-minute walk distance, may improve some saturation. The same thing is reported here also. Another additional trial that shows that there is not much benefit with adding therapy. So the conclusion of the various studies that there is insufficient data to support routine upfront or early sequential oral combination therapy in Eisenmenger syndrome. It should be considered in patients who have markers of adverse outcome or clinical deterioration while on monotherapy. So that is where we stand. So unlike in idiopathic pulmonary hypertension, combination therapy is not the way to go forward in Eisenmenger syndrome. So there are very few studies of selexipag that are there, and there is no data regarding selexipag in Eisenmenger syndrome. So all the patients improved. There are very small studies. So what about the other heart failure medications that we have? We all know that Eisenmenger syndrome patients die because of progressive heart failure, or they die because of a sudden cardiac death or hemoptysis. We have looked at the part of hemoptysis before. So our group were actively investigating the role of metoprolol, because most of these children or most of these adolescents are relatively well preserved. They have a very long life to go, say maybe around 20, 30 years to live at the max, or maybe around 10, 15 years to live on an average. So we thought that their most important cause of death are sudden cardiac death and progression to heart failure. So the most important drug that can prevent it is a beta blocker. So this was the first observational study that we did in 15 patients. There was a significant improvement in 6-minute walk distance. We gave hemodynamic measurements in all patients who are getting catheterized at baseline, and 15 mg of IV metoprolol, and after 6 weeks, we again recatheterized them, and we showed a significant improvement in hemodynamics with no change in oxygen saturation. They are relatively well tolerated in a very selected subgroup of Eisenmenger syndrome. So the PVRI did come down over time. So our conclusion was short-term beta blocker therapy is well tolerated, may be effective in improving effort tolerance in selected patients of Eisenmenger syndrome. With this in background, with a lot of struggle, we ended up this first ever randomized controlled trial of beta blocker in any form of pulmonary hypertension. So we took 60 patients with Eisenmenger syndrome. We used a double-blind placebo-controlled design, and 30 patients were randomized into the metoprolol group, and 30 patients were into the placebo group. And unfortunately, we couldn't replicate the observational result that we got there is not much difference in 6-minute walk distance, which was our main primary endpoint. Not only that, more number of patients had clinically significant worsening. So the metoprolol group also increased the NT-proBNP levels as compared to the placebo group. Significant increase in NT-proBNP was there. So in general, we did not improve the 6-minute walk distance among patients with Eisenmenger syndrome. Not only that, it led to possible clinical worsening. So at the current stage, the specific therapy, the most important recommended therapy is bosentan, which is a class 1B recommendation. In patients with adult patients, you can think of other ERAs, that is ambrisentan or mesitentan, PDE5 inhibitors, riociguat and prostacyclin analogs, and prostacyclin receptor agonists may be considered. Sequential combination therapy is what is recommended. So always start with bosentan, then you add the other agent if the patients don't improve. That's a significant difference from how do we manage an idiopathic pulmonary hypertension. Apart from the drug therapy, the only other treatment that works is generally a lung transplant or a heart lung transplantation. So generally, they are reserved for very high-risk patients when they present with an inadequate response to treatment despite optimal combination therapy, and they are at an intermediate to high risk of death. That is a 1-year mortality of 10% with current treatment. Then what is recommended? Generally, the reveals risk score of greater than 7 is what is recommended in patients who have inadequate response. Listing is generally done greater than 10. Despite subcutaneous and intravenous prostacyclin. That is when the listing is done. So this is the other question that I had in mind, that a 22-year-old female, a class 2 Eisenmenger, saturating 87%, wants to conceive. So what should be our advice? So our advice should be, pregnancy is almost absolutely contraindicated. So this is one condition where the mortality maternal risk still remains very high in the range of around 30%. The low prospect of successful pregnancy, especially if the maternal oxygen saturation is below 85%. The majority of death happen in the second trimester to the peripartum period. So spontaneous abortions are very high. The premature delivery is 50% and IUGR is 30%. So the current recommendations are strongly against pregnancy and advise interruption of pregnancy if it does occur. So one more thing is, we have always been taught that Eisenmenger syndrome have very good long-term prognosis. And when you compare with IPH, this is what been told to us. But unfortunately, the recent data, the recent analysis from the Swedish subgroup and other things have shown that there is what is known as immortal bias. So the lower survival is when immortal bias is accounted. They tend to have a lower survival as good as the idiopathic pulmonary hypertension. So the meaning is that many of the patients actually die when they reach adolescent age group. If you are a clinician who start looking at adolescent patients with Eisenmenger syndrome only, you may think that they have a better longevity. So once the immortal bias is accounted for, Eisenmenger syndrome survival is not as great as the thing. What are the major predictors of survival? Are the complex Eisenmenger syndrome or pre-tricuspid lesion? They are the ones that predicted the things. So to conclude, Eisenmenger's remains no intervention disease, and it's possibly where a cardiologist should become an expert in medicine. The old-time physician is what is needed in managing hypertension, the Eisenmenger syndrome. What we need is, first of all, we should do no harm. Do not operate when in doubt. Do not do a phlebotomy unless indicated. No elective surgeries, no pregnancies. You just give them a contraceptive advice. No unnecessary diuretics, no polypharmacy, or early prophylactic transplant. Then drugs help in symptomatic improvement in selected patients. Be judicious in decision making. Thank you for your patient listening.
Thank you, Dr. Rima Christman. Actually, you have a very nice topic. Actually, although we have less and less difficult situation, it's still very, very challenging. A very nice topic. Thank you. And we will move forward to the last speaker in this section from Dr. Chen Dao. He will introduce his topic is the pulmonary hypertensive crisis in pediatric arterial hypertension during cardiac catheterization. Dr. Zhang, are you there? Please.
Thank you.
Okay.
Thank you for introduce.
Yeah, sure. Just a break. Good.
Okay. Good afternoon, everyone. My topic is pulmonary hypertensive crisis in pediatric pulmonary arterial hypertension during cardiac respiration. Pulmonary arterial hypertension, PAH, is a group of disease characterized by increased pulmonary vascular resistance, PVR, and pulmonary arterial pressure, PAP, due to various causes, eventually resulting in right ventricular failure and even death. Cardiac catheterization is the gold standard for the diagnosis of PAH and can provide comprehensive hemodynamic information to confirm the diagnosis, determine disease severity, and guide the selection of treatment. But cardiac catheterization is invasive and risky. The most important complications in pulmonary hypertensive crisis, PHC, it can occur at various stages of procedure. It is an important cause of perioperative death, and it cannot be completely avoided. Although similar to adult PAH, pediatric patients have many own characteristics, such as general anesthesia is needed in most cases. Hemodynamics are susceptible to fluctuations, sensitive to pain, prone to vagal reflex and arrhythmia, sensitive to fasting, prone to inner environment disorder. Pediatric patients' pulmonary vessel has more pulmonary vascular hypertrophy, less internal fibrosis, and few plexiform lesions prone to spasticity. Therefore, the incidence of PHC in children is much higher than that in adults. PHC is first proposed in 1979 in a case report, but there is no unified definition yet. Here is our proposed definition. Because of severe contraction of pulmonary vessels result from various factors, acute rise of PVI and PAP lead to clinical status of severe hemodynamic collapse. For right heart system, there are venous congestion and insufficient pulmonary perfusion. And for the left heart system, there is no cardiac output. In our experience, patients with some risk factors are more prone to PHC, including general anesthesia, WHO function class 3 and 4, without systemic pulmonary shunts, small age and low weight, history of PHC or recurrent syncope, response to pulmonary activity testing. Among these factors, general anesthesia is the most important. There are three kinds of reasons for PHC. First, the factors causing pulmonary vasoconstriction, including hypoxia, acidosis, respiratory depression, drugs, stimulus of operation. Second, the factors increasing heart burden, including arrhythmia, nervous, and pain. Third, the factors causing inadequate systemic perfusion, including fasting, hemorrhage, and vagal reflex. The mechanism of PHC consists of multiple links. Main links include pulmonary vasoconstriction, right heart failure, low cardiac output, and acidosis. These links form a vicious circle. Each link can be both a cause and a result. For patients undergoing cardiac acceleration, we can identify PHC by hemodynamic manifestations. Some important indicators are useful for diagnosis. First, PAP. This parameter significantly rises early, but may decline when the heart failure is serious. And sometimes it's not easy to detect the change process. Second, central venous pressure. It reflects poor compensation of right heart function and has good sensitivity and specificity. Third, arterial pressure. Rapid and obvious decline of this parameter has important diagnostic value. Fourth, heart rate. This parameter may decrease, stable, or increase during PHC, but severely decrease indicate PHC is serious and the CRP may be needed. Fifth, blood oxygen saturation. This indicator can act as early warning signal of PHC. According to our experience, CVP and AP are two accurate and easily measurable indicators. In addition to hemodynamic changes, PHC is often accompanied by some other manifestations. Blood gas analysis usually indicates acidosis. Many respiratory acidosis, especially in patients under general anesthesia. In severe cases, respiratory and metabolic acidosis may coexist. Imaging examinations such as X-ray or echo will show progressive enlargement of the right heart. At the same time, the left heart becomes very small. Once PHC occurs, we should stop the operation, remove the including factors, improve ventilation and hypoxia, mechanical ventilation and hyperventilation if necessary, maintain vital signs, CIP if necessary, inhaled or intravenous pulmonary vasodilator, such as alloprost, NO, triproscythemia, improve heart function and atrial pressure, correct acidosis and arrhythmia. If the PHC is life-threatening and irreversible, emergency ECMO, lung transplantation, or cardiopulmonary transplantation may be considered. According to our experience, mild PHC with good cardiac function can alleviate spontaneously without special treatment or after high concentration oxygen inhalation and or improved ventilation. For typical PH with hemodynamic collapse, most can be gradually relieved after acute treatment, but may progress to life-threatening PHC without appropriate treatment. And for severe PHC with a very poor cardiac function, it cannot be resolved by active conventional treatment without ECMO lung transplantation. This is a typical case of PHC with typical hemodynamic indicators and X-ray changes. Some measurements can be taken to prevent the occurrence of PHC, including carefully preoperative risk assessment, pulmonary vasodilators used before operation as appropriate. For patients with poor WHO function class, adequate perioperative heart support is necessary. maintain fluid balance and internal environment stability, find and correct internal environment disorders early, especially acidosis and hyperoxemia. Improve anesthesia management and minimize the influence of anesthesia and hemodynamics. Gentle and skillful operation. Avoid operational stimulation, shorten operation time, reduce operation hemorrhage. Finally, I'd like to summarize my content. PHC is an important complication in pediatric PAH during cardiac catheterization. PHC is essentially acute right heart failure with no cardiac output, leading to hemodynamic collapse. General anesthesia is the most important inducer of PHC. Raised CVP and dropped AP are the most important indicators for PHC. Early and comprehensive treatment may be improved outcomes of PHC. Thank you very much.
Yeah. Okay, thank you. Thanks, Dr. Zhang.
You can stop presenting so that we can. Yeah, I think the topic is open for discussion. So I will start with Dr. Arun. So you said about dapagliflozin. So do you consider this as a class effect with empagliflozin, or sotagliflozin will have the same effect, or do you think DAPA is more effective, or you don't have the correct information?
Yes, I think as of now, data in pediatric heart failure is minimal, but considering adult data, there is suggestion that it is a class effect. But at the same time, you must note that both dapagliflozin and empagliflozin initially, the initial trials in adult heart failure were not unequivocally favorable. But I think dose identification and optimization was responsible to have. That's the reason we are now seeing more or less equivalent benefits in adult heart failure. So I think it is most likely a class effect in pediatrics, but we need more data regarding the optimal dose.
So I think in response to your article, there are some comments that we should plan an RCT. But is it ethical to withhold such an efficient therapy in heart failure? So what is your thought on that?
I understand the concern, but I think as long as it is not recommended in any of the guidelines, we may be justified to randomize. Once it comes in a guideline, then we might, it may not be clear. I would like to know the opinion of the House as well.
I think I just want to add here. Yeah, I just want to add here. So we just completed a thesis on dapagliflozin compared to placebo in 20 patients each. Like, it's a small study comparatively, but then what we found was that whatever BNP improvement happened in the dapagliflozin group, same improvement happened in the placebo group also. And then there were some incidences of hyponatremia that were noted, but they were not therapeutically important hyponatremia. But once you are measuring repeatedly, by the definition, they fall below the level. Below 130 is what we defined as hyponatremia. So they were falling into that zone. But the same thing was the same in both groups. So compared to whatever has happened in pediatric heart failure, like for example, the way the ARNIs have failed, the way the beta blockers, there is no data, but still we end up using it, and maybe we'll end up doing the same with DAPA. The only issue here is that if you are planning for an RCT, it has to be reasonably good sized, adequately powered RCT, unlike the other pediatric heart failure trial, which are very good studies from the pediatric background, but they were not sufficiently good enough to answer the question.
Dr. Do, any comments?
Yeah, but we don't have any experience on this topic. Actually, see that we have limited data on this, the published data on this topic. I would like to the same question to Dr. Gopal Krishna. The what kind of dosage of this kind of dapagliflozin you do use in your clinic setting?
We use 0.1 to
0.1.
0.2 to 0.2 milligram per kilogram per day, once daily.
Okay. Okay, thank you. So,
this drug, do you consider the recurrent urinary tract infection? Because in the other study, there was an incidence of 16% UTI. So in your study, the UTI was not that much a problem. Only an asymptomatic bacteriuria was there. So do you consider, because many of the patients may not be reporting the urinary symptoms. So do you want to routinely monitor the urinary sediments to find out whether the patient is going for UTI, or what is your recommendation?
I think we were aware of the results of previous studies, so we were conscious regarding, and we had counseled the family also that there is an increased need for addition to genital hygiene and watching after every void. So that is probably helped us in our case. But at the same time, we must identify that even the child whose genital candidiasis was identified, that was actually picked up by us. It was not identified by the parent. So I think proper advice and close monitoring will be more useful than just identification of urine routine, because pyuria or bacteriuria alone may not help us in deciding on antibiotic treatment for these children. And one thing is that they seem to be tolerating it well, and we don't have, even in another studies so far have reported Fournier's gangrene or major genital infections in the published data so far in children.
So coming to the next topic, Dr. Dai. So it was interesting to see that one page you showed a case where a patient with a left bundle branch block improved after correcting the conduction block. So if you see left bundle branch block, what is your routine practice? Will you to go for correction of that, or what is your routine when you see an LBB and heart failure, especially in pediatric population? CRT, what will you first go for, CRT, or what is your yeah?
Thank you for your question. In our clinical practice, if the child is more than 3 years old and the weight is more than 10 kilogram, I will perform LBBP for this child. You know, biventricular pacing, CRT, traditional CRT, is very hard to perform in such young children. And LBBP just 2 leads, and patients more than 3 years old can be performed. You know, CRT maybe need to combine with operation, surgical operation. So I have about 14 patients, such kinds of patients. They all get improved left ventricle ejection fraction, and the ventricular size decreased. A very good effect. I haven't read an article, but I think LBBP benefits such kind of children. Maybe without this kind of therapy, these children will face with transplantation of heart transplantation. Maybe such kind of CRT can make such kind of patients have normal heart function to have normal life.
Okay, thank you. Another question is that you have done the ablation. The patient is supposed to be cured, but the LV function will take time to recover. So how long will you give the guideline-directed medical therapy to these patients? Will you continue lifelong, or will you stop it once the LV function improves?
You mean the such kind of patients with left branch block?
No, any tachycardiomyopathy,
Ablation.
you do the ablation. Patient, the arrhythmia is no more there, but the LV function apparently improves. But will you continue the heart failure drugs for the patient? How long will you continue? What is your practice?
Ablation can make such kind of patients with TIC get normal cardiac function. If tachycardia recurred, I will perform another ablation for such kind of patient. And successful ablation can get this kind of patients normal heart function and heart size. I have follow up for about the longest follow-up is about 10 years. They remain normal.
So what about the drugs? Will you continue stop the drugs completely, like ARNI or SGLT2 inhibitors or the heart failure drugs? Will you stop completely?
No, the meditation will continue.
No.
The meditation will
How
continue.
long? How long will you continue?
If the LVEF is normal, I will stop some of the drugs. But if the left ventricular size not normal, maybe ACEI will be continued.
No, it just depends. Some patients recover very quickly, like after atrial tachycardia or something. You did ablation, and the result very good. So the left ventricular function, also the size become normal very quickly. So this kind of situation, and the question is, it take how long? 多长时间? How long for the patient to recover? And then you stop the medication.
Some patients maybe when 1 month, and the largest maybe 1 year about.
Yeah.
And I think the most difficult for us is to distinguish the patients is idiopathic dilated cardiomyopathy or TIC. I think it is quite difficult. In some cases, maybe the P wave is just hard to distinguish from the sinus pattern.
Okay.
And also the case 2, I think it is very, very rare. Just PVC or accelerated idioventricular tachycardia. I think it is generally considered benign. But in this patient, the significantly decreased left ventricular function.
Yeah. Actually, the key question for you is how to tell the difference between ideal dilated cardiomyopathy or the secondary cardiomyopathy due to arrhythmia. Actually, in some children, like some children with dilated cardiomyopathy in the late stage, they will have this kind of like a preventable beat. How can you distinguish them? How to tell the difference?
I at first I cannot distinguish them. For the girl, I perform ablation because that when the infusion of antiballoon, the atrial blood pressure is evaluated, and the patient feel good. I think at that time, I think if I if the ventricular PVC, if PVC is eliminated, I think the patient will benefit from it. But whether she will recover totally, I don't know. But follow up tells me ventricular, the PVC and VT attributes to his heart failure. The result tell me.
Okay, and there's another question for you, Dr. Dare. What's the QRS duration cutoff that is considered for children to be considered for LBB pacing?
It's a very tough question. I think the guidelines for adult is not suitable for children. You know, the cardiac conduction speed is not. In my 14 patients, the QRS duration are all above 130 milliseconds. But I don't know the criteria.
Okay, thank you.
Thank you.
Okay, to Dr. Ramakrishnan, so you did the beta blocker study, but how many of them had a RV dysfunction, right ventricular dysfunction? So did that group benefited, or like we have ventricular dysfunction for left ventricle, no beta blocker has a benefit. So did it benefit in that group?
So I think we excluded patients with because it's a first ever randomized control study. We excluded patients with obvious RV and LV dysfunctions. So this is a selected patients who are reasonably well. Clinical heart failure was excluded. So we took a relatively stable patients. Then also they were not tolerating. Like at least 5 patients worsened clinically after beta blocker.
Okay. Any other comments or questions?
Yeah. What kind of beta blocker do you prefer to use for this situation?
So in the study we used metoprolol sustained release 25 mg. They were all adult patients, so we started with 25 mg twice daily, increase it to 50 mg twice daily if the blood pressure and other things were under control.
Okay. Okay, thank you.
Any other comments regarding the pulmonary hypertension crisis? What is the how is nitric oxide useful? What is the practice?
Yeah.
Can you hear us?
Maybe.
Can you hear us?
The question is for Dr. Zhang, right?
Yeah.
Okay. Oh, sorry.
Nitric oxide, use of nitric oxide in a pulmonary hypertension crisis.
Pardon.
What is the role of nitric oxide? Any role for nitric oxide, and what is the practice if you encounter a pulmonary hypertensive crisis?
Nitro 一氧化氮。
他是问一氧化碳什么？
对对对，就说你在这个危急的时候怎么用这个？就是你do the pulmonary and do the catheterization when you see the crisis, how do you manage with this kind of medication?
Okay, there are no more. No more comments. We will wind up this session. So thank you so much, Dr. Arun and Dr. Ramakrishnan, Dr. Du, Dr. Dai, and my co-chair, Dr. Sang, all those people who participated. And I thank all the Asian Heart Society for giving us this opportunity, and wish to have more sessions in the future. So thank you so much, and we are on time, I think. So thank you. Over to Dr. Du for your comments.
Thank you. Thanks. Very nice. Yeah, very nice session. Thank you.